Good evening, everyone, and welcome to the Saving Wrentham and Hogan Alliance Open Board Meeting. I'm so grateful that you are here. Board members, partners, families, advocates, and friends. Your presence matters. As we continue discussing the future of IDD services in Massachusetts, it is important that we recognize Wrentham and Hogan for what they truly are: specialized clinical care campuses. These campuses provide intensive multidisciplinary supports that cannot be replicated in standard community settings, and our language should reflect that reality. We must stop referring to Wrentham and Hogan as institutions. They are specialized clinical care campuses, centers of expertise that deliver essential clinical services unavailable anywhere in the state. This presentation gives us an opportunity to speak plainly about where we are, what we are seeing, and what we believe must happen next to protect individuals with intellectual and developmental disabilities in Massachusetts. Our focus is not simply one facility, one budget line, or one policy dispute. Our focus is choice, the right of individuals and families to have a real continuum of care, including specialized residential options when those options are clinically appropriate, humane, and preferred. The quote on this slide is our North Star, and I want you to hold it through everything we discuss tonight. Choice is only meaningful when the options are real. If a family is told they have a choice, but one of the options has been closed, defunded, or quietly removed from the table, that is not choice. That is an illusion of choice. And the Saving Wrentham and Hogan Alliance exists to make sure the options are real. So let's look at the moment we're in, because it's a serious one. We are at a crossroads. Federal Medicaid pressure is growing, and states will be forced to make difficult decisions about where reductions will fall. When budgets tighten, the people most at risk are often those with the highest needs and the least political power. For individuals with severe and profound IDD, that risk is especially serious. The population is small. It is not a large voting bloc. It is often spoken about by others rather than heard directly. And too often, policy decisions are made around them instead of with their families, guardians, clinicians, and direct caregivers. Look at the right side of this slide. Smallest population, least political power, most complex needs, decisions made around them, not with them. That is not a description of people who are well protected by a political system. That is the description of people who are vulnerable to it. That is why Saving Wrentham and Hogan Alliance exists. We are here to insist that high acuity individuals not be treated as budget problems to be managed, but as people whose lives, health, dignity, and choices matter. And we are not talking about future risks in the abstract. This is already happening. We are already seeing this pressure play out in Massachusetts. Governor Healey's consolidation plan within the DDS system has been framed as a cost-saving measure, but for the 100 individuals affected, This is not an abstract administrative change. It means relocating people from long-standing, stable placements into new settings, disrupting medical routines, trusted relationships, behavioral supports, and daily structures that have taken years, sometimes decades, to build. The proposed closure of the Pappas Rehabilitation Hospital for Children reflects the same concern. Although Pappas serves a different population than Wrentham and Hogan, the policy logic is familiar. Close specialized public capacity, call it modernization, and move medically complex individuals into systems that may not be equipped to provide the same level of care. Now, let's talk about the financial argument because we hear it constantly. The hidden cost column on this slide tells the real story. When a specialized public facility, such as Pappas, is closed, the state may lose federal matching support. The state may increase reliance on higher cost private providers, and there will be downstream costs, crisis placements, hospitalizations, transportation, and fragmented care. What appears to be a savings on one line of a budget can become much larger elsewhere. We need policymakers to follow the full dollar, not just the line item that looks good in a press release. And this is not a one-time problem. It's part of a pattern we are seeing across Massachusetts and nationally. Saving Wrentham and Hogan is noticing a pattern, both nationally and here in Massachusetts. And I want to walk you through it step by step, because understanding the pattern is essential to understanding what we are seeing. Step 1. States declare a commitment to community-based services. That language sounds positive. It signals inclusion, modernization, and progress. But the phrase community-based can mean many different things. It can mean well-funded, clinically appropriate services. It can also mean thinly funded programs that depend heavily on unpaid family labor. Step 2. Responsibility shifts to pet families through self-directed or parent-run models. These models can be empowering when they are adequately funded, staffed, and supported. But when the workforce is collapsing and services are unavailable, families become the workforce by default. Step 3. Provider agencies and intermediaries are inserted into the system. Families may be told they have control, but the model often still requires fiscal intermediaries, administrative brokers, and service coordinators. Those entities are paid first. Families and individuals absorb the gaps when the services are not delivered. Step 4. Staffing shortages shift the burden onto parents and guardians. Round-the-clock supervision, behavioral crisis management, medical monitoring, transportation, coordination, work that should be supported by a system, silently transferred to exhausted families. Step 5. Budgets are cut later, while intermediaries continue to receive their share. The structural drivers on the bottom of the slide tell us why this happens. Budget pressure, workforce collapse, political optics, administrative capture, and fragmented oversight. Self-direction can sound empowering, but without adequate funding and staffing, it becomes a cost shift. Community can sound humane, but without infrastructure, it becomes abandonment by another name. So, what does the Saving Wrentham and Hogan Alliance do about it? Let's talk about our response. The Saving Wrentham and Hogan Alliance uses three main levers to protect the rights, dignity, and care of individuals with IDD. 1, legislative advocacy, 2, education, and 3, legal planning. This is where the presentation shifts from the problem to our response. Our first lever is legislative advocacy. Over the past year, our partner, COFAR, strengthened its advocacy capacity through Maura Drummy's work as Deputy Director of Advocacy and Development. Maura led the effort to include choice of model of care language in the budget process, and the Saving Wrentham and Hogan Alliance joined that effort. Although the language did not pass, several lawmakers supported it. That matters. We now have a clearer picture of which legislators understand the importance of preserving real choice. And those are the relationships that we will continue to build. Our second lever is education. A great deal of misinformation continues to circulate in the IDD and autism communities. Our website, blog, and social media channels are designed to provide timely, accurate information, correct misconceptions, and explain why the full continuum of care matters. Our digital reach is growing, and that gives us a stronger platform to inform families, professionals, lawmakers, and the public. Our third lever is legal planning. We are exploring legal strategies that protect informed choice, challenge systemic barriers, and ensure that individuals who need ICF-IID level of care are not steered into inappropriate settings simply because the state has narrowed the practical options available to them. The education lever leads us directly to this slide because we need to address the misconceptions head on. Let's spend a few minutes on the misconceptions that show up most often in policy debates, in media coverage, and even in conversations with well-meaning advocates. Because misinformation shapes policy, and correcting it is one of the Saving Wrentham and Hogan Alliance's core responsibilities. Misconception number 1. Home and community-based services is always cheaper than facility-based care. For lower acuity individuals, some community-based models may be appropriate and cost-effective. But for high acuity individuals, that assumption does not always hold. The ICF-IID model has an integrated cost that is visible in the Medicaid daily rate. Residential care, clinical support, therapy, medical oversight, staffing, and infrastructure. HCBS costs are often fragmented across multiple systems: transportation, crisis response, emergency medical care, day services, behavioral supports, and critically, unpaid family labor. When those costs are counted honestly, HCBS is not automatically cheaper for people with severe and profound needs. Misconception 2. Modern ICF-IID care is the same as institutions of the past. This misconception is powerful because the history was real. The abuses exposed at places like Willowbrook and Belchertown should never be minimized. But the lesson of that history is not that every campus-based setting is inherently abusive. The lesson is that underfunding, neglect, abandonment, and lack of oversight are dangerous wherever they occur. Today's ICF-IID facilities operate under a very different regulatory and clinical framework. Individualized treatment planning, medical and behavioral supports, staffing standards, monitoring, and residential rights protection. The comparison to the past is not only inaccurate, it prevents honest discussion about what some individuals need today. Misconception 3. Massachusetts has already solved the IDD care situation. Massachusetts has made some progress, but much of that progress came after litigation, family advocacy, and sustained pressure. We should not confuse a positive reputation with a fully functioning system. For individuals with severe and profound IDD, major gaps remain. Limited access to ICF-IID admissions, inadequate high acuity community capacity, crisis-driven placements, and fragmented oversight. Misconception 4. Federal policy changes mean people will be forced into institutions. This one gets repeated often, especially now, and it misframes the actual danger. The real danger is not that families will be forced into ICF-IID care. The more likely danger is that families will continue to be left without appropriate services at all. If ICF-IID admissions remain effectively closed and community systems remain underbuilt, high acuity individuals may end up in ER boarding, psychiatric units, crisis placement, incarceration, or family homes where exhausted relatives provide extraordinary levels of unpaid care. That is not inclusion. That is abandonment. We don't take on these misconceptions alone, and that brings us to our partnerships. Our partnerships are essential, and I want to recognize them specifically. Some partners have already provided direct help. Others strengthen our credibility, broaden our reach, and make clear that this work is part of a larger coalition. COFAR has been a strong and consistent partner in legislative advocacy and budget language. Their work on the House floor and in committee relationships directly supports the Saving Wrentham and Hogan Alliance goals. The National Council on Severe Autism, and particularly legal policy fellow Christina Gaudio, is helping us think through legal strategy with real depth and precision. Her expertise is invaluable as we develop a careful legal roadmap. VOR has helped us promote our cost analysis and our lawsuit series and has been an invaluable resource for understanding the national landscape, what is happening in other states, what strategies are working, and where the risks are heading. The Wrentham Family Association helped the Saving Wrentham and Hogan Alliance possible at the very beginning by donating the startup funding we needed to get organized and moving. The Mass Nurses Association helped turn our cost analysis into a practical advocacy tool by publishing hard copies that could be distributed directly to key lawmakers. AFSCME 93 is also an important partner to name. Their support, along with the support of our other partners, gives this effort credibility and signals that the concerns we are raising are shared beyond one organization or one family group. As we continue to learn from families, clinicians, direct care staff, and advocates who understand the real world consequences of these policy decisions, their voices are not background noise, they are the evidence. Our meetings with state officials, including the commissioner and other decision makers, are part of that work. These conversations focus on choice, inclusion, continuity of care, and the financial and human consequences of narrowing the continuum of services. Our goal is not to oppose community care. Our goal is to make sure community care is not used as a slogan to eliminate other necessary options. And that leads us directly to what we are looking for. The Saving Wrentham and Hogan Alliance is asking for something straightforward, a real continuum of care. That means every clinically appropriate option must be disclosed, evaluated, and practically available. Not disclosed in theory, not available on paper, practically available when a family needs it. Community-based services for those who want them and can safely benefit from them. We support this. We and our partners have always supported this. Preserve and reopen access to ICF IID care for individuals whose needs require that level of integrated support. These two things are not in conflict. They are both part of a real continuum. Person-centered planning based on clinical facts, not a predetermined outcome. A person-centered system cannot predetermine the answer before the clinical facts are considered. And a humane system cannot leave high acuity families to manage crisis care alone. The line at the bottom of the picture says it plainly. Inaction is not neutral. The choice we protect must be real. A family cannot make an informed choice if one option is never disclosed, never evaluated, or never practically available. Silence and inaction have consequences, real ones, for real people. Let's look at what those consequences look like when nothing changes. If nothing changes, this is what the status quo looks like. Placement crises continue. Individuals remain caught in unstable, disrupted arrangements, not because there is no better option, but because the better option is not accessible. Emergency systems absorb the unmet need. ERs, psychiatric units, hospitalization, and crisis placements fill the gap at high cost, with no clinical continuity, and with none of the specialized support that these individuals actually need. Hidden costs keep rising. The true price surfaces elsewhere in the system, not on the closed budget line, but in emergency departments, in family breakdown, in staff turnover, and in the long-term deterioration of individuals who need something something that the system refused to provide. And here is the one that keeps me up at night. Wrentham and Hogan could disappear, not by formal closure, but by attrition, by underfunding, by the gradual redirection of admissions until one day they exist on paper, but no longer serve anyone in need. Specialized options can vanish in practice for future generations. even if they remain technically available. And that is what inaction produces. I want to close by returning to the people at the center of all of this. The individuals we are talking about are not abstractions. They are sons and daughters, siblings, neighbors, and members of our Commonwealth. Many cannot advocate for themselves in traditional ways. This places a responsibility on all of us to speak clearly, accurately, and persistently. The Saving Wrentham and Hogan Alliance will continue educating families and officials. We will continue legislative advocacy. We will continue public messaging to correct the record and grow our reach. We will continue building partnerships with organizations that understand the importance of choice. And we will continue developing a thoughtful, strategic legal approach to protect access for high acuity individuals. Our message is simple, and I want to leave you with it. Community care matters, but community care cannot be the only answer for everyone. True inclusion requires real options. True person-centered planning requires honest disclosure. And true choice requires preserving the settings that some individuals need in order to live safely, stably, and with dignity. Thank you for your time, your commitment, and your continued support of the Saving Wrentham and Hogan Alliance. I am proud to stand with every one of you in this work. Thank you for listening, and please feel free to comment.